So my name is Larissa Finley, and I'm the marketing manager at Computeries, and I'm the VP of Education for the Greater St. Louis MGMA. So I would like to officially welcome you to our annual Medicare meeting, and we are virtual this year. So thank you to everyone on the Education Committee for coordinating this meeting and all of the great educational programming this year, and all of the rest of the board. We've scrambled and tried to provide some value and to try to keep engaged with this wonderful organization. So before we start the meeting, we have some upcoming dates to keep in mind. Our next meeting is on March 10th, and that's going to be a webinar from 12 to 1 p.m. on the toolkit to manage any employee problem, presented by Marcia Powers, Human Resources Consultant of Epoxy Healthcare. Then on April 14th, Barbara Foppel, longtime MGMA member and practice manager at Allergy Consultants, will be speaking on diversity and inclusion in the workplace during the webinar, which is also from 12 to 1. Then in May, on the 12th, we have Stacy Christensen, Director of Healthcare Brand Strategy at Professional Office Services Incorporated. And she'll be presenting a webinar on marketing and communications to improve patient engagement. So another exciting date that is coming up is the Missouri MGMA annual conference, which is named Riding the Waves in Healthcare. Tickets are on sale now for the May 5th through 7th event, and that's being held at the Hilton Branson Convention Center. And you can learn more at our website, MGMA, or at their website, www.mgma-mo.org. So now is also a great time to renew your MGMA membership if you haven't done it already. So if you're new this year, you can become a member today. You will get member pricing for all of the meetings in our annual conference. You can renew and sign up online at mgmastl.org or contact our chapter administrator, Kara Nagel, at administrator@mgmastl.org with any membership inquiries you may have. Just so you know, the grace period ends soon at February 15th. So if you haven't paid your dues by then, you won't be able to log on to the website. So definitely make sure you renew before then. We appreciate all of our members and invite our guests here to join and renew and be part of this great organization. So some reminders for this meeting: the session is eligible for 2.5 AAPC CEUs for everyone in attendance today. We will be sending out the certificates via email later this week, along with the on-demand recording of today's presentation. So I wanted to take a minute to give a big thank you to the sponsors of today's Medicare update. Our gold sponsor is Keene Insurance Group, and our silver sponsors are Epoxy Healthcare, Sandberg & Phoenix Law Firm, and R3 Dynamics. And these contributions really help to fund events like this and also provide engagement from the business partners. And it's because of the business partners that we can provide excellent education activities and some fun things to do also when we can hopefully get together soon. So with that, I would like to check the chat really quick. Okay, good morning, good morning. Nice to have everyone join us today. We have so far 33 participants for this virtual event. So I hope you have questions ready for Ellen, because she's ready to answer them. Absolutely. So I'm going to switch over to, hold on 2 seconds. We have a video from one of our sponsors, Keene Insurance, to welcome us.
The Keene Insurance Group.
Oh, let's start over.
Good morning. Thanks for tuning in today. I wanted to welcome you to the St. Louis MGMA 2021 Medicare update. I'm Jeff Evenstrait with the Keene Insurance Group. Today, we're going to be featuring both Ellen, who you've heard from many times over the years, an expert in her field, and her co-worker, Mary, They're going to talk to you about this year's updates in Medicare and how to maximize your billing and your billing functions. Wanted to mention a little bit about myself and our company. Again, as I mentioned, I'm Jeff Hebenstreit of the Keene Insurance Group. We're a longtime supporter of St. Louis MGMA and love our partnership with you, and appreciate the opportunity to be here this morning. We specialize in medical professional liability insurance. Our roots go back to the mid-'80s with our founder, John Keene. We currently broker and assist over 5,000 physicians and other healthcare providers around the United States, but our home is in Missouri. We've actually assisted many of the members of St. Louis MGMA for over 20 years. A longtime partner to the members, again, specializing in assisting with their medical professional liability insurance. And as you're well aware, we've seen some tumultuousness in the medical professional liability insurance industry over those last 20 plus years. And I'm glad to say we're still here and our partners are still here, and we look forward to serving you well into the future. So having said that, I would invite you to contact myself or any of the brokers at the Keene Insurance Group, and we can talk about what your options are, how we might be able to assist, and perhaps some other product lines such as long-term and short-term disability insurance, health insurance, business owners insurance, and any other insurance needs you may have. So without further ado, I'd like to go ahead and introduce our speakers today, Ellen and Mary.
Okay, so I think that worked. Thank you for that, Jeff. Ellen, if you wanted to go ahead and reshare your screen at this point, I will do the formal introduction for yourself and Mary, who will be joining us in just a moment or so. Mary Muchow is a specialist within the Provider Outreach and Education, the POE department at Wisconsin Physicians Service, WPS Medicare. She has nearly 40 years of Medicare experience with WPS GHA, and for over 20 years as an investigator and later as a Medicare fraud information specialist. Mary acted as a liaison with CMS, federal law enforcement, and other entities tasked with detecting and preventing fraud, waste, and abuse. Mary joined the POE team in 2003, and she enjoys her role in outreach activities, including the development of professional and productive provider partnerships with members of various societies and organizations. She also serves as a member of CMS's National Medicare Learning Network Provider Education Work Group. And also we have Ellen, who you've already seen on the meeting today. She's joined us multiple years in the past, and we always enjoy her presentations. So Ellen Berra, CPC, is a senior analyst with the Provider Outreach and Education Department with Wisconsin Physicians Services, WPS Medicare, and has been with Medicare for over 36 years with experience in many different aspects of Medicare, including claims entry, appeals, customer service, and the most recent Provider Outreach and Education. Ellen is the co-chair of the WPS Medicare Provider Outreach and Education Advisory Group, the POE-AG, a group responsible for identifying and assisting with educational needs of the provider community. As part of this function, Ellen has developed numerous articles and educational materials for the listserv and website, and has developed and presented many types of education, including seminars, video presentations, and teleconferences. Ellen works with several provider organization partners to provide individualized education suited to the specific needs of the organization. So thank you very much for Ellen and Mary for being here. And then I will turn it over to you, and we can officially start our presentation. And you can put questions in the chat as they come up, and I will address them with Ellen and Mary. So I'm going to mute myself, and it's all yours, Ellen and Mary. Thank you.
Good morning, everyone. This is Mary. Can you hear me all right?
Yes, we can hear you.
Wonderful. Well, it's my pleasure to get started with this What's New for 2021 Medicare Updates program today. With that being said, I do want to point out something in the handout that all of you should have received, and that is our disclaimer statement. We use this disclaimer in all of our education, and we do so because we want to let you know that our review and approval processes for published education takes time. We need to remind you that changes can occur before the live education is conducted. So for this reason and other reasons as well, we do include this disclaimer statement in our education. Alan and I did the best we possibly could to make certain that all of the information included in this presentation today in your handout is absolutely up to date. But Medicare rules can and often do change. So please keep that in mind. Any relevant laws, Medicare regulations, and rulings found on the CMS website will always prevail. Please do feel free to share this information that you've received today, but point out that there is that disclaimer there. Well, much of the information that Ellen and I are going to talk about today was published recently in the final rule. We do want to just back up a little bit and talk about the rulemaking process itself. Specifically, the rulemaking process in that how it really affects our Medicare providers. So we're going to start with that. On page 2 of your handout, there is a graphic. It's taken from the United States Government Accountability Office website, and it really does a nice job at illustrating the rulemaking process. The bulleted items on the same page of your handout explain that process in writing. So I'm not going to go over them all individually. Just point this out to you that there is a designated process in the rulemaking. Often called the congressional watchdog, the Government Accountability Office gets its authority to issue regulation from laws. We also call those statutes. These are issued by Congress, and typically during the rulemaking process, the GAO will publish an advance notice of proposed rulemaking. That proposed rule is published in the Federal Register for public comment, and so that the President can also take an opportunity to review the rule as well. The specified comment period, usually 30 to 60 days, can vary. It could be extended, and it may even be reopened. After considering public comments and internal reviews, the GAO will publish the final rule in the Federal Register. So that rulemaking, if you look to the next slide then, the rulemaking that updates Medicare's payment policies, rates, or other provisions for services that are furnished under the Physician Fee Schedule, or PFS for short, is known as the Medicare Physician Fee Schedule Final Rule. And as mentioned on page 3 of your handout, the final rule is integrated into the Code of Federal Regulations, also known as CFR. The CFR then is codification of general and permanent rules that are published in the Federal Register by departments and agencies of the federal government. So you can find the published Federal Register online. The electronic version allows for simple search and navigation. The URL is included in your handout and also listed on the same page of your handout. Under the last bullet is the URL for the calendar year 2021 Medicare Physician Fee Schedule Final Rule that was put on display on December 2 of 2020. So looking to the next slide then, when you hear someone from WPS-GHA or CMS speak about the Medicare Physician Fee Schedule, or PFS, what we're really talking about here is the basis of payment for all Medicare items and services. Over 10,000 services, that is. So items on the Physician Fee Schedule are funded by Part B, and for each code on that, there are associated costs for 3 different elements. And those elements are work expense, practice expense, and malpractice expense. So each of these components then has a relative value unit, or an RVU, that is assigned. Now, it's probably safe to say that almost everyone recognizes that the cost of doing business in one part of the country is not the same as doing business in the other part of the country. So because of this, all RVUs are adjusted based on what's called the Geographical Practice Cost Index, or GPCI, GPCI for short. So you can find pricing for WPSGHA MAC Jurisdiction 5 and Jurisdiction 8 on the WPSGHA website, and directions for navigation to those pricing files on our website are included on page 4 of your handout. Now, in addition, at the bottom of page 4 of your handout, you can find the URL for CMS's Physician Fee Schedule Lookup tool, and this allows the user to easily drill down a search for pricing information. So, on to the next slide. CMS uses what we call transmittals to incorporate changed policies or procedures into its internet-only manual system. And there's a link to transmittals on the CMS website homepage. Now, one type of transmittal is what we call, or what we know as, a change request. You might hear us call it a CR. CRs are notifications about changes that CMS is making to instructions in one of their internet-only manuals. So in addition to the link to transmittals on the CMS website, or on their homepage rather, there's a link to the CMS manuals, that particular homepage. And by selecting the link to manuals, you can choose those internet-only manuals in order to access the manual of choice. There's all different kinds of manuals. I think there's 26 or 27 of them. A couple of examples of CMS internet-only manuals that we often go to and quote from are the Medicare Benefit Policy Manual and also the Medicare Claims Processing Manual. And all of those manuals are numbered. So you might hear someone at WPSGHA refer to Publication 100-04. Well, that is the Medicare Claims Processing Manual. So each of them are numbered, and I wanted you to be aware of that. Because the language in change requests, or CRs, is often riddled with a lot of technical terms, the CMS Medicare Learning Network will also publish an associated MLN, or Medicare Learning Network Matters article. These MLN articles provide easy to understand information about those changes to the Medicare program that are being incorporated into those internet-only manuals. So it's that information published in the change request that changes that language in the IOM, the internet-only manuals, but the MLN articles explain them in easy to understand language versus that technical language that the change requests are full of. So you can search the Medicare Learning Network article list, getting ahead of myself here, on CMS's website. You can search by subject, or you can search by article. You can use common words in the article indexes in order to quickly find related MLN articles. The URL to search MLN articles is found on page 5 of your handout. Now, let's move on to changes for calendar year 2020, specifically the payment policies under the physician fee schedule and other changes to Part B payment policies. Now, just as we have mentioned before, this includes all of those policy and payment changes under the physician fee schedule for 2021. If you don't want, or you don't need specific information about these changes, you can just go out to the website and look specifically for what you are trying to find, but otherwise, in totality, you'll find all of the great information that we're going to cover today in this physician fee schedule changes, payment policies, and changes for Part B payment policies this year. You can find on the next slide information that we've included in this presentation today about the conversion factor for calendar year 2021, the physician fee schedule. The conversion factor is a multiplier that Medicare applies to those relative value units in order to calculate reimbursement for a particular service or procedure under the physician fee schedule. So for calendar year 2021, the conversion factor originally published in the final rule represented a 10% reduction to the calendar year 2020 conversion factor. But on December 27th, Congress, in the Consolidated Appropriations Act 2021, modified that calendar year 2021 Medicare physician fee schedule. So the legislation actually provides a 3.75 increase in the Medicare physician fee schedule payments for calendar year 2021. We did publish a Medicare Learning Connects, or Medicare Learning Network MLN Connect special edition back on January 6th of 2021 concerning this change. But because the physician fee schedule pricing was already calculated and published to our website before that new legislation, those fee schedules were removed and then later replaced with the updated fee schedules. So those fee schedules are now published to our website and are accurate. You can see on this slide the conversion factor for 2021 is $32.40, and you'll also see the final anesthesia conversion factor published there, $20.05. Next, I want to talk a little bit about budget neutrality, and one significant factor that impacts the physician fee schedule is that any changes that are made to the fee schedule must be what we refer to as budget neutral. So what this really means is that an existing upward payment for an existing or new code will actually require an offset or downward adjustment in another area. This is what we refer to as budget neutrality, and it is indeed mandated by Congress. When Congress provided the 3.75 increase in the Medicare physician fee schedule payments, due to the mandate for budget neutrality, the implementation of the inherent complexity add-on code for E&M services is now being delayed until calendar year 2024. That's how CMS was able to offset those upward payments for services and still maintain budget neutrality. So due to the 2021 increases in work RVUs for E&M services, which actually represent nearly 40% of all services billed and 20% of the total spending under the Medicare physician fee schedule each year, pricing for 2021 services are going to impact certain specialties more than others, particularly those that do not normally bill E&M service. So at the bottom of page 7 of your handout, you can find a link to Table 106, and this is a table that's found on page 1660 of the final rule. This shows the calendar year 2021 physician fee schedule estimated impact on total allowed charges by specialty. And I've left this in here because we've heard a lot of providers talking about this and how this impacts their specialty. But we do, of course, recognize that while the estimated impacts for some specialties is welcome news, it is not really welcome news for others. But WPS-GHA is unable to debate those changes. Next, I want to talk a little bit about changes to deductibles and premiums. Each year, Medicare premiums and the deductibles are adjusted, and these are adjusted according to the Social Security Act. Each year, we include Part B deductible and premium amounts in our What's New education programs and programs such as this one that we're doing today. Amounts for 2021 are listed on page 8 of your handout. So for calendar year 2021, the Part B annual deductible actually increased $5 from $198 in 2020 to $203 in 2021. The standard monthly premium for most Part B enrollees has actually increased $3.90 from $144.60 in 2020 to $148.50 in 2021. Approximately 7% of Medicare Part B enrollees will actually pay a higher standard monthly premium, and this is based on income amounts. So for those amounts and for more details on 2021 changes to both Part A and Part B premiums and deductibles, you can refer to the fact sheet that was published by CMS, and the URL is located, the URL for that fact sheet is located under the last bullet on page 8 of your handout. Some additional changes in the 2021 amounts that we want to talk about today is the new amounts in controversy. The statutory formula for the annual adjustment to amounts in controversy, or what we call AIC, these are threshold amounts for various levels of the appeals process. That's what we're talking about, those amounts in controversy for some of those levels. There is an AIC for 2 of the appeals levels. There's 5 appeal levels. The threshold amounts, the AIC threshold amounts that are applicable to levels of appeal are at level 3, the administrative law judge hearing level, and level 5, the judicial review level in federal court. This is set forth, these amounts in controversy are actually set forth in the Social Security Act. And the amounts in controversy for calendar year 2021 were actually published in the Federal Register back on September 28th of 2020. The amount in controversy for level 3 hearings, that's those administrative law judge hearings, is $180 in calendar year 2021. And the amount in controversy for the level 5 judicial review for calendar year 2021 is up to $1,760. There is a link to the resource that provides further details. In your handout, it's provided on page 9. It's important to remember also that while only level 3 and level 5 appeals require that you meet this minimum amount in controversy, there are time frames for requesting all 5 levels of appeal that need to be adhered to. So just throwing that in there as a reminder for you. Next, I'm going to talk about 2021 changes that affect the National Correct Coding Initiative, or NCCI files. CMS implemented this initiative, the NCCI, or National Correct Coding Initiative, to make sure that claims are being correctly coded and to ultimately reduce the improper payment rate for Part B claims. All of these edits are used by the MACs, and this includes the Durable Medical Equipment MACs, all in an effort to reduce that improper payment rate for Part B claims. I've included the URL for the version updates that are effective January 1, 2021 on page 10 of your handout. You'll see that listed there. These represent modifications to the procedure-to-procedure and medically unlikely edit published edit files for previous quarterly version updates. So those are effective January 1 of 2021. Also included in your handout is a link to the CMS web page that includes the edits. If you navigate to that page, one of the items that you're going to see listed there in the left menu pane is the National Correct Coding Initiative Policy Manual for Medicare. A revised annual version of that manual was posted in December. It's effective January 1 of 2021, and the additions and revisions to the manual are actually shown in red font so that you can easily notice them. Prior versions of the manual are available also. They still remain available actually in the NCCI Policy Manual Archive, and that's also available as a link in that left menu page of the CMS web page that's listed there on your handout for you. Providers are really encouraged to use that manual that I just talked about. It includes a lot of helpful information about the edits, including the use of NCCI-associated modifiers. A couple of those, for example, are the modifier 25 and the modifier 59. So some great information available there. Also included in your handout are URLs for each of the 3 types of NCCI edits. That's the procedure-to-procedure coding edits, the medically unlikely edits, or the MUEs, and the add-on code edits, all part of the National Correct Coding Initiative. The edits are published on a quarterly basis and are available on the CMS website. Keep in mind that you're going to need to select the edit files depending on your provider type. So, for example, are you a professional? Are you, or rather, a practitioner? Are you a facility, the hospital? Are you a DME supplier service, et cetera? There's different types of files listed out there that, for these particular edits. If you're interested in learning more about the National Correct Coding Initiative, we have a very helpful on-demand course titled National Correct Coding Initiative. What is it and how do I use it? And that particular course is located in the WPS GHA Learning Center. Let's move on and talk a little bit about 2021 changes for policy. Back in 2013, in the August 7, 2013 Federal Register notice, quite some time ago, CMS establish current procedures for requesting a national coverage determination or a reconsideration of an existing national coverage determination, or an NCD for short. CMS described how the public could participate in the NCD process during the indicated comment period. They also established an expedited administrative process to remove the old NCDs, or those that were older than 10 years, thereby allowing the local MACs then to determine coverage for that particular item or service. In the 2021 proposed rule, CMS proposed to use the notice and comment rulemaking to identify and remove those older NCDs that they believed no longer contained clinically pertinent or current information, or that no longer reflected current medical practice. They explained that eliminating an NCD does change a substantive legal standard that's related to Medicare coverage and payment that is addressed in the Social Security Act, specifically that the items that were covered nationally under the Social Security Act would no longer be automatically covered by Medicare, and instead, in the absence of an NCD, a national coverage determination, that determination for coverage for those particular items and services would now be made by the MACs. MACs then would now be able to cover the item or service, and as long as the MAC determined that such action was appropriate, of course, under statute. So, in other words, the item or service could be covered still by Medicare as long as it was deemed to be medically necessary. So just as I discussed earlier in my presentation today, when I explained that rulemaking process, a public comment period followed the publication of the proposed rule about these changes for NCDs. You can view the comments received and the CMS responses in the calendar year 2021 final rule. And on page 11 of your handout, you can find the 6 national coverage determinations, or NCDs, that were actually removed by CMS effective the date of the final rule. So in the final rule, then, CMS states that changes in coverage require an implementation process in order to make required changes in manual guidance, as well as coding and coverage and payment system edits for items and services. They also, in the final rule, stated that while it typically takes a number of months to implement a change in coverage, the implementing change requests will take those time discrepancies between effective and implementation dates into consideration. And they're going to do this to make certain that claims are adjudicated appropriately, retroactive back to the effective date of the final rule. So just some things to remember. Next up, specific to 2021 changes, I want to talk about some changes that are therapy related. There are multiple therapy related issues that were brought about with the 2021 calendar year. Relative value units, those RVUs for therapy evaluations, were revalued and increased, and this is commensurate with the increased values in 2021 for office and outpatient visits. Alan's going to talk about that a little bit later on today, the changes for office and outpatient services, that is. What you need to know if you're a therapy biller is that the reimbursement for the therapy itself has not been increased. It is the RVUs for therapy evaluations that were revalued and increased. So for calendar year 2021, one of the therapy-related issues that CMS has clarified is that physical therapists and occupational therapists can delegate furnishing of maintenance therapy services. Of course, they would need to be clinically appropriate, and they can delegate furnishing maintenance therapy services to physical therapy assistants and occupational therapy assistants. This allows the same discretion to delegate maintenance therapy services to PTAs and OTAs that the therapists are currently, or had been using, rather, for rehabilitative services. There's no changes to what a PTA and OTA can render. That really is based on state scope of practice. There's also no changes to the supervision requirements that are required by Medicare. Only that CMS has clarified that PTs and OTs can delegate furnishing of maintenance therapy services in addition to those rehabilitative services for 2021. You can find all of this information on page 12 of your handout. There's also information about medical record documentation on your handout that I've included in this therapy session. Specifically, CMS has clarified that their broad policy principle that allows billing clinicians to review and verify documentation added to the medical record for their services by other members of the medical team also applies to therapists. CMS has also clarified that a therapy student or students of other disciplines who are working under a physician or a practitioner who bills Medicare directly for their professional services can document in the medical record, and as it's reviewed and verified by the billing physician, practitioner, or therapist. And what this really means is that Medicare will expect that the documentation is actually signed and dated by that billing provider. So some things to keep in mind as it relates to medical record documentation. Finally, for 2021 therapy services, CMS has increased the per beneficiary threshold amounts for the use of the KX modifier. For those that don't know, the presence of the KX modifier demonstrates that the services that are billed qualify for the therapy cap exception. They're reasonable and necessary services that require the skills of a therapist, and that those services, those medically necessary services requiring the skills of the therapist, are appropriately documented in the medical record. Therapy services submitted without the KX modifier for claims above the therapy threshold will deny. Now, you can find some additional background about those per beneficiary threshold amounts in the MLN Matters article that's listed at the bottom of page 12. The URL is provided for you. That particular article also addresses the section of the Bipartisan Budget Act of 2018 that maintains the targeted medical review process for therapy services. For 2021, there's no change to the medical record threshold amount as it pertains to targeted medical review processes for therapy. Moving on now to the next slide, I'm going to talk a little bit about non-physician practitioners' supervision of diagnostic tests. CMS is making permanent the current COVID-19 public health regulatory flexibility that does allow non-physician practitioners to supervise the performance of diagnostic tests. So for calendar year 2021, CMS is finalizing the proposed policy regarding supervision of those diagnostic tests by certain non-physician practitioners, with a modification to include certified registered nurse anesthetists to that list of NPPs who are eligible under the Part B program to supervise performance of diagnostic tests. Of course, these would be under applicable state law and scope of practice. Those are listed on your handout, those NPPs that may supervise those diagnostic tests. Now, while medical doctors and doctors of osteopathy were previously the only professionals who were authorized under federal regulations to supervise performance of diagnostic tests, CMS has finalized the listing of those non-physician practitioners who are now eligible to supervise the performance of diagnostic tests. And of course, state laws and scope of practice would apply. These non-physician practitioners must still meet the supervision requirements under Medicare regulations that govern their respective statutory benefit category. To find the level of supervision that's required for diagnostic tests, or if the concept itself applies or doesn't apply, you can refer to column Z. It's titled Physician Supervision of Diagnostic Services, and that column Z is the column that appears on the CMS relative value file that I talked about early on in my presentation. Specifically, it will tell you the level of supervision required for certain diagnostic tests. And remember, those services on the relative value file are listed by CPT code. Next up, I'm going to talk about Naloxone and opioid treatment programs. Starting back on January 1 of 2020, CMS will pay for opioid treatment programs. They do so through bundled payments for opioid use disorder or opioid use disorder treatment services in an episode of care that is provided to people with Medicare Part B. So those services included under the benefit are listed on page 14 of your handout. For calendar year 2021, CMS is expanding those bundled payments to be inclusive of all substance use disorders. Also, in the 2021 Physician Fee Schedule Final Rule, CMS has finalized the proposal to extend the definition of opioid use disorder services to include Food and Drug Administration opioid antagonist medications, specifically Naloxone, for emergency treatment of opioid overdose, as well as overdose education. So CMS has created a new add-on code to report the cost of providing patients with nasal Naloxone. They are finalizing the proposal to apply a frequency limit on the codes describing Naloxone, but will, of course, allow exceptions in the case where the beneficiary overdoses and uses the supply of Naloxone given to them by the opioid treatment program, to the extent that the additional supply of Naloxone is, of course, medically reasonable and necessary. Also, beginning in 2021, CMS is going to allow periodic assessments to be furnished via two-way interactive audio-video communication technology. There are some really great resources listed on the bottom of page 15 of your handout that really kind of dives more into the weeds on this particular topic, or provides greater detail, I should say. We don't have time to go into all of those details, but we did want to provide you with an update to the best of our abilities today. Next, in your handout and in our slide presentation is just a little bit of information regarding the delay in implementation of the appropriate use criteria, or AUC. In August 10, 2020 announcement, CMS announced that the educational and operations testing period for this program, the appropriate use criteria, or AUC program, has been extended through calendar year 2021. So what this means is that there are no payment consequences that are associated with the appropriate use criteria program during both calendar year 2020 and now calendar year 2021 is also. CMS and all of the MACs encourage stakeholders to use this period to learn, to test, and to prepare for that AUC program. The URL for the CMS appropriate use criteria webpage is included on page 17 of your handout. WPSGHA will, of course, consider topic-related education as soon as CMS publishes further instructions or directions to the MACs, the Medicare Administrative Contractors, to provide that topic-related education. This brings me to the end of my prepared remarks for today's presentation.
Thank you, Mary. Okay, so the next thing that we're going to be talking about then is home infusion therapy. And on your first page there in your handout, you have information concerning the MLN matters, or MM11880. That CMS has published concerning home infusion therapy services. The next one that you have listed is the new specialty code that will apply to professionals billing for this service, and that's the D6. And then there's also a special edition that you have available there for you that just provides you with some more information on this. So with home infusion therapy, this is kind of a new situation with Medicare. And so the first thing that you have to do is you have to enroll with Medicare as a home infusion therapy provider. Now, in your handout, it shows you there that you have to be accredited through a CMS-approved accrediting organization. Now, CMS did not provide us with information on necessarily who those accrediting organizations are at this time. However, in your handout, we did provide you with an email address to CMS. So if you are not aware of what organization you need to contact in order to receive that accreditation, you can send an email to that email address. When you're enrolling with Medicare, you will enroll using the standard 855B as in boy enrollment application. This is considered a professional service, whoever is providing this. And of course, you don't want to use the paper application. The paper application just takes longer. There's more chance of error. What you want to use is to use the provider enrollment chain and ownership enrollment online system. One of the big advantages to that is as you're going through the presentation or through the application itself, once you get ready to submit that, it can come back to you if there are any errors on that particular form. So using the online system is just better for everybody. It's better for you, it's better for us, and it is faster. Also on your handout, you can see who is eligible to become a home infusion therapy provider. And this is physician offices, home health agencies, DME suppliers, etc. And then, of course, we have the specialty listed there for you, the D6. Now, when you're doing the online application, there's a space in there where you would have a drop-down box for the specialty that you want to enroll under. Currently, the last that we know, D6 is not an option, but that's okay. What you do is you hit Other, and then you simply type in the D6. And of course, then all of the other standard enrollment requirements would apply. So this next, what you have up on your screen now is just kind of an infographic concerning the different components that go along with home infusion therapy. You can see there that there's infusion drugs, there's the equipment through which these drugs are administered to that patient. You also have other non-drug supplies. This is going to be the tubing, catheters, all of that kind of stuff that go along with that. And then the next one is the home infusion therapy professional services. Now the first three, the infusion drugs, medical equipment, and supplies, all of those are going to be billed by the DME supplier. You would not bill for any of those. The next one, the professional services, that's what physicians' offices can actually bill for. So the next graphic or the next slide that we have discusses the procedure codes for the home infusion therapy services. And you can see there that there's different categories. Category 1, for an example, intravenous, anti-infective, pain management, etc. Category 2 is subcutaneous immunotherapy, and then category 3 is going to be your chemotherapy and other drugs like that. You'll also notice on this slide that there are 2 different procedure codes for each of the categories. One is the initial visit and then also the subsequent visit. Now, in order to use an initial visit, the patient must not have been receiving or must not have received home infusion therapy for a period of 60 days. Medicare calls this an episode of care. So if the patient has not had home infusion therapy for 60 days, then you can bill that initial visit code. If Medicare sees other visits within that 60-day time frame, then of course you would need to use the subsequent care code. If you're providing services in more than one of these categories, you want to choose the category that will provide you with the highest level of payment. So for an example, and I don't have the particular amounts in front of me, but if you're doing something in category 2 and category 3, more than likely category 3 is going to be the highest payer. So you can only bill one of the procedure codes, and in that case, you would choose that G0090 or G0070. Now, the other thing with these home infusion therapy is that you bill for this procedure code on the date when you have someone in the patient's home and on a date that they are receiving the home infusion therapy through that equipment. Services are billed all on one line, And what we mean by that is if you have multiple units, and you can see on your handout that there are time increments for this, but what we mean is that, for an example, if you had 2 units of service, which is 23 minutes to 38, this has to be on one line, and then, of course, with the multiple units of service. If you look on your next slide, we'll talk about the different services that are provided as part of the professional services for home infusion therapy. You can see they're listed. We have training and education, dressing changes, site care, assessments, etc. Now, a qualified HIT supplier, which we're talking about the professional services here, can only bill for the HIT therapy on days when a professional, and this could be your physician or practitioner, it could also be your ancillary staff that are part of this, is physically present in the patient's home and the drug is being administered. Now, part of the services include monitoring or remote monitoring services. These can happen obviously on a date other than the day of the actual infusion. You would not bill separately for that. That would simply be part of the total service that you're providing to the patient. So you would not add additional time to your home infusion therapy procedure code, additional units of service, anything like that. That's simply built into the reimbursement itself for the home infusion therapy services. So the next thing we want to talk about then, and this is on page 22 of your handout, is a new service that CMS is now covering, which is acupuncture for chronic low back pain. Now on your handout, again on page 22, we have 2 different references for you. One is the National Coverage Determination itself that talks about the coverage for this, goes into who can provide it, etc. And then we've also provided to you the Medicare coverage database where you can go into the actual national coverage determination for this particular service. So on your handout, we've got information there, kind of an overview of the acupuncture for chronic low back pain. You can see here that Medicare can allow up to 12 visits within a 90-day period for patients with chronic low back pain. And then it also provides you with a definition on your handout, lasting 12 weeks or longer, non-specific. It doesn't have, or you have not been able to identify yet a specific reason for the patient to have that low back pain. It's not associated with surgery. It's not associated with pregnancy. Medicare can also allow an additional 8 sessions if the patients are demonstrating an improvement. So that's going to go back to your documentation. How was the patient's range of motion or their statement of their level of pain to begin with, and then after they've had treatment, how is it now? If the patient is not improving, then Medicare would no longer cover those services. No more than 20 treatments can be provided annually. And of course, again, the treatment must be discontinued if the patient is not showing improvement. The next section on your handout talks about who can provide these services. And you can see here it's a master's or doctorate level degree in acupuncture or oriental medicine from an accredited school. They have to have a current, active, and unrestricted license to practice acupuncture within their state or their area. And then the services can be provided by other staff. And so what we mean by that is that this can be provided under an incident to provision, but the person providing it still has to meet that same requirement that was listed above, the master's or doctoral level degree in acupuncture or oriental medicine. And so we have provided you there the information for the internet-only manual talking about Incident to services. There's a lot of requirements that go along with Incident to services. The person providing it has to be listed as an employee of the person who's going to bill for it, has to be provided in an office. Direct supervision has to be provided, which means that the person billing for the service has to be within the office suite at the time services are being provided. And so all of that information is listed for you there in that internet-only manual reference. The next thing that we want to talk about is, I think, a really pretty big change, and this is on page 23 of your handout. And this is where providers, non-physician practitioners, are now going to be able to certify and supervise patients under home health. Prior to this change, and this change actually became effective March 1st of 2020, although it will be implemented, or was implemented January of 2021. So what this means then is that rather than only a physician or a physician MD or a DO, they're not the only ones who can now certify the patient. And what we mean by certification is the fact that the patient meets the qualifications in order to receive home health care. That can now be done by a non-physician practitioner. What this change also means is that non-physician practitioners can also now provide that supervision. This is the care plan oversight services, and those procedure codes for both the certification, recertification, which happens every 60 days, and then the care plan oversight services are listed there for you. So that's the information that we have to provide you really on session 1 at this time. So what we would like to do, Larissa, is go ahead and open it up for any questions before we get started on our next topic.
Okay, that sounds great. And so let's just see what kind of questions. You can put the questions in the chat, and then I will help moderate that for Ellen and Mary. So let's give them a minute. But thank you very much for that information. There's lots of changes definitely going on. So let's give people a couple more minutes.
Okay.
And there's 43 of you out there. I know one of you has to have some sort of question. We will see. So Ellen, where are you joining us from today?
I'm actually joining you from Texas.
Ah, have you had any snow there this winter?
No, we have not had snow. Here in our area, we are expecting freezing rain, and frankly, no one down here knows how to drive anyway. That's one of the things I noticed when I moved down here. My dad used to tell me, my dad was a long-distance truck driver, and he used to say that people in Texas and Oklahoma don't know how to drive because they're used to riding horses, and therefore horses don't have blinkers. Horses don't wait to look for blind spots before they change lanes. They just go. And I really believe that that is true. You have to keep watching these people all the time.
I love it. Love it. Love it.
It's very interesting.
Well, Stacy had a comment that we don't know how to drive in the snow either. So we're, how about Mary, where are you joining us from today? And you're on mute. Oh, there you go.
I am freezing in Wisconsin.
Oh my goodness.
It is just horrible. Oh, and it's not going to get much better until early next week. But yeah, I've got a heated throw. on my lap, and a warm sweater on, and I'm just thinking of warmer places to be, but I don't have to go anywhere. And we can drive in the snow. I have had an overnight accumulation of 17 inches of snow at one point, and actually went into my office later on that afternoon because we have the equipment to move it. So they do a great job. Hats off to all of those people out there keeping us safe on our roads.
Well, that's good to hear. We're kind of in the middle of you guys, right in the St. Louis area. And so most of our snow has been in February. And this is a reminder, if anyone does have questions, I'm just filling in time so you can think of some questions. We are going to take a little break in just a few minutes. But yeah, so we've had most of our snow in February this year, which is very interesting. And somehow last night had half of an inch of snow and some freezing rain type something. And then they're like, oh yeah, that's not enough to plow. And the roads were interesting this morning. So yeah.
We actually had snowquakes earlier this week where you could hear popping and such outside from the ground, the cold and such. It's very interesting.
Wow.
But we had no snow up until late January, really none to speak of. So it arrived late, and I hope it leaves early.
So Dan said, first day of spring is only 6 weeks away. Hang in there.
Yay.
So if there's, it doesn't seem like we have any questions right now. So I think we're going to go ahead and take our 15-minute break, if that's all right. So people can get up, move their legs around. I'm going to share my screen. We have some slides from our sponsors and MGMA. And then in about 15 minutes at 9:45, a little after, we will come back and do a some sponsor videos and everything like that, and then go into session 2. So again, for time frame, we have 15 minutes until 9:47 for our break, when I'm going to be on mute, and you can view the slides, get up, do what you need to do, get more coffee, all of that. And then at 9:47, we will be back for some 10 minutes of sponsor presentations, and then back for our session 2. So let's see. And Diane says, hang in there, everyone. Glad we can at least get together virtually. Can't wait to see everyone in person again. I miss handshakes and hugs with all my friends and colleagues. We miss you too, Diane. Absolutely. So officially break time. Thank you, and we'll see you in just a little bit. Okay, everyone, it is now officially time to end our break. Hopefully you've gotten up a little bit, got the blood moving, get some coffee, get a little snack. Snacks are allowed even at 9:45 in the morning. So we are going to move into some of our sponsor videos. So bear with me as we go through a few of the videos. So here we go. The first one is from our silver sponsor, Epoxy Healthcare.
Running a medical practice is hard work. Epoxy Healthcare offers practices a trusted partner with the right skills and experience to help your team manage the administrative side of business so physicians can focus on patient care. Epoxy offers a myriad of services, including HR support, interim practice management, revenue optimization, EMR implementation and support, and so much more. At Epoxy, we don't just write a report. We get down in the trenches with you and your team to implement a plan that positions you for success even after we leave. And because our entire team of consultants have previously been practice administrators, we know exactly how to navigate the challenges you face every day. Here's what some of our clients say about working with us. Our practice was a hot mess behind the scenes until we brought in Epoxy. They helped us figure out the gaps in our processes and implement changes that not only made things more efficient, but made our staff and managers happier. I used to call my attorney for all my HR issues, but he could only give me legal advice. With Epoxy, I get actual solutions I can use for my HR problems. We never realized how much money we were leaving on the table until we hired Epoxy to help us optimize our revenue cycle management. Contact us today so we can become the glue that holds your practice together.
And next we have another video from our silver sponsor, Sandberg Phoenix.
Hi, I'm Vivek Patel, CEO of Sandberg Phoenix. Sandberg Phoenix is a full-service law firm providing transactional and litigation services across the Midwest region. To me, Sandberg Phoenix is different and unique because we're a values-based law firm. Not only do we provide value to our clients, but we provide value to the people that work here. Every day, it is the goal of Sandberg Phoenix to be a value-based led law firm. Our brand reflects who we are. Sandberg Phoenix wants to be fresh, innovative, entrepreneurial, family-oriented. We changed our brand to match who we are. We made it colorful. We made it energetic. We made it exciting because that's how we feel Sandberg Phoenix treats its people and its clients. Sandberg Life is everything, from recruiting initiatives to our diversity and inclusion initiatives to our women advancement initiatives. It's getting to know each other. It's our civic involvement and our social accountability that we expect from each other. Clients expect extraordinary service. That's what we do for them every single day. Not only do we just say it, we actually guarantee it. We believe in order to deliver amazing client service to our clients, it is crucial that our team members are happy, fulfilled, and enjoy being at Sandberg Phoenix. We're a place that actually just rocks it for our clients.
Hi, I hope you've enjoyed the first session of our St. Louis MGMA Medicare update. I know I've learned a lot over the last session, and I hope you have too. As mentioned earlier, I'm with the Keene Insurance Group. We're a longtime supporter of MGMA and have assisted many of the MGMA members over the last 20 plus years. I would invite you to contact us. I know that we are entering a time that we're going to see some shifts in the marketplace. We're going to see price increases. We've seen carriers exit the market, and I wanted to let you know we can be a resource for your medical professional liability needs. As a full service professional liability insurance brokerage, we have multiple options that would save you time, money, and preserve or enhance the quality of your coverage. I'd invite you to contact us at KeeneInsuranceGroup.com or myself, Jeff Evenstrike, at 314-822-6934. I look forward to serving you. Now we're going to get back to our speakers, Ellen and Mary.
Okay, so we made it through the videos. Technology is wonderful, what can I say? Does anyone have any other questions before we start off? We're a little bit ahead of time. Any questions before we get started? Can you all hear us?
I can hear you.
Okay, so we do have a question from Diane. What has been the most common questions you have seen since the implementation of the changes this year?
That's a really good question. I think there's a couple of things you can look at. One, I think the changes always to the National Coding Initiative that Mary talked about. Providers sometimes don't necessarily go look for those to see what has changed each year, and then they're kind of surprised when they receive a denial message. I think another one has to do with therapy. Mary talked about that, the fact that the actual therapist can now delegate to their PTAs, OTAs, not only the therapy services, but also maintenance therapy services. I think that has been a big one. On our website, we have a document or an area, I guess you could say, that you could look at that has to do with frequently asked questions. And so our customer service department, both from the phone calls that they receive and then also inquiries that they receive, take a look at the most common questions that they're receiving, and then they answer those through that Q&A section available on our website. Mary, can you think of anything else?
Well, initially we had a lot of questions about the fee schedules that were there and then were gone and came back, but that really has remained not an interruption for us, certainly. I can't think of anything else, Ellen. I think that you hit the nail on the head with the therapy questions. Some of the questions that we've gotten from therapy, and I tried to talk about it a little bit while I talked about the therapy changes this year, concerned what an OTA and PTA can do. And that nothing's changed there. That remains the same as it always was. They have to be acting within their state scope of practice. The services would need to be medically necessary, of course. But really the difference there was the fact that CMS has added in addition to their rehabilitative therapy services, the maintenance therapy services that can be delegated to them. So that's all I can think of right now, Ellen.
Diane says, thank you. That's very pertinent guidance. Does anyone else have anything? Okay, so even though we are a little bit ahead of schedule, I think that we can go ahead and start with session 2, if that's all right. And then we'll have more questions at the end. And if you guys wanted to pause in between, like some of the subsections to ask for questions, that might be a good thing. But I will let you reshare your screen, Ellen, and officially start session 2.
There we go. All right, so what we're going to talk about next then is going to be the E&M office and other outpatient changes for 2021. And I'll apologize in advance, but I am going to make that statement, office and other outpatient, several times as we're talking about this, because I want you to be clear that this only affects the office or other outpatient procedures. The changes that we're getting ready to talk about do not affect your inpatient services, your skilled nursing facility services, emergency department, critical care. It does not have anything to do with those services. This will be a brief overview. We're actually doing a teleconference tomorrow that will go a little bit more in depth into the different changes that we're getting ready to talk about. That registration is available out in our Learning Center, and the website for that is http://www.wpsghalearningcenter.com. If you're not already registered through that, you can register, and then you can sign up for that course. That particular course will only be open for registration through about 2:30 this afternoon. And then there's instructions in there on how you need to enroll with our direct vendor, the call vendor for tomorrow. And then you'll receive an email back from them that provides you with a telephone number and a unique ID for that. And you need to take care of both of those things in order to hear the teleconference tomorrow. We have an on-demand training currently out there, and this is a question and answer document. We've done several pieces of education on the office and other outpatient changes for 2021. And as part of that, we have developed, I think we're about up to 28, 30 pages, somewhere around in there, questions that we have received from the provider community, and then we're providing answers to that. We also have a YouTube video that's available. That's probably about 20 minutes or so, and you can go into the WPSGHA YouTube channel in order to find that. As part of the education from tomorrow, we will be placing this as an on-demand training. So you'll be able to hear the recording. The question and answer document will be part of that, in addition to the American Medical Association, or AMA, document that talks about these changes also. Now, evaluation and management services has always been, regardless of whether it's office or other outpatient or anything else, has always been more of a gray area than choosing a procedure code to remove an appendix or something. And so evaluation and management changes and responses that we may give to questions that you submit to us can change. There's additional information coming out from CMS. There's discussions that we have internally with our medical directors. I have taken some of the questions to them, and it's like, Okay, I don't know which way to answer this, and so our medical directors have come back. The question and answer document really does have a lot of great information in it. Not only does it refer back to the rules and regulations that CMS has published, which is really going back to the American Medical Association document, but it gets into some of the more real-life situations that you can have within your offices. Like I said, it's a 28 to 30-page document. If you have a question that is not currently in there that you think would be valuable, you can certainly submit that as part of the presentation that we're doing tomorrow. So as we continue to learn more, we will continue to update that Q&A document. CMS has the evaluation and management guidelines available. Well, they did have it available on their website that went through the history exam and medical decision making. They have removed that document. As of this morning, it was no longer there. They are working on revising that document, and then we'll replace it out on their website when they get it done. Now, when we're talking about evaluation and management services, the biggest thing to keep in mind is that the service has to be medically necessary. And that all goes back to your documentation. What is it within the documentation that shows that the encounter between the patient and the practitioner on that date is medically necessary for that patient? So what are some of the changes that we have? Well, number one, again, it applies only to office or other outpatient services. Providers have told us that they really do not want to have one set of guidelines, history exam and medical decision making for some services, and then time and the new medical decision making guidelines for their office or other outpatient. Unfortunately, though, that's simply the way that it is right now. Whether there will be changes coming to the description and how you choose a level of service on these other categories of services, that's going to be determined by the AMA, and then also whether or not CMS will agree to those changes. There's also changes to the prolonged services for office or other outpatients. And then you'll notice on here that we have complexity listed. In your handout, we provide you with that procedure code, the G2211. As Mary stated earlier, when we put together presentations, there's review and approval process we have to go through. And so we were not able to kind of remove this at this point. And really, I didn't want to. This procedure code is out there. It's in the HCPCS book. It is not going to be available for use, though, until January 1st of 2024. Currently, CMS has changed the designation for this procedure code to a B as in boy status, meaning that it will simply be bundled into anything else that you have going on that particular day. So for office and other outpatient services beginning January 1st of 2021 and after, you'll choose your procedure code based on either time or the medical decision making as described by the American Medical Association. So on page 25 of your handout, we have a listing there for you of the times as described in the CPT book for each of the different office and other outpatient codes, 99202 to 99215. Now, a couple things you want to think about when you're billing based on time. One of the changes is that the way this is worded within the CPT book is different now than it was worded last year. Last year, time was mentioned within the description of codes, but it was more a typical time. And so if you were using time in order to choose a procedure code, you had to meet a midpoint. You no longer have to do that. So if you look on your handout, you can see there the procedure code 99202 says 15 to 29 minutes. Well, as long as you have 15 minutes documented, then you can choose that procedure code. When you're choosing your time, it is only the physician or practitioner's time that chooses that procedure code. Time that your ancillary staff spend rooming the patient, doing vitals, all of that kind of stuff, that time does not count toward the time that you would use in order to choose your procedure code. Another big change is that time is going to include both face-to-face time and non-face-to-face time. A later slide provides us with some information on that. This slide also has some of the things, the non-face-to-face things, that as long as you have it recorded within your medical record and your physicians are keeping track of the time that they spend on that, then that can go into the choice of the time. You can see here it can be preparing to see the patient, reviewing the chart, as long as it's on the calendar date. Now that's a very important distinction. We've heard from a lot of providers who indicate that, well, can I use a 24-hour? You know, the patient comes in at 3 o'clock, can I use any time that I have spent since 3 o'clock yesterday? And the answer to that is no. It's only time spent on that calendar date. Some practices have let us know that their process is that the day before, the physician reviews the charts, reviews the medical record for patients that are going to come in the following day. That time that you spent yesterday is not going to be part of the time that you would bill to us or that you would use in choosing your procedure code. You can also see here time that you spend performing an exam, ordering services, and that last bullet point, documentation. So let's think about what that one means for a minute. If your physician dictates his or her note, then the time that he or she spends dictating that note, that's part of the time that you can choose. If your physicians and practitioners are actually entering into the medical record, they're actually doing the typing, then that time that they spend can also count toward the time in order to choose your level of service. And again, it's only on that calendar date. Time does not have to be spent in counseling and/or coordination of care. That was effective for services in 2020. For your office or other outpatient services, that rule does no longer apply. So if we look then at the next slide, not separately reported. This is a statement that the American Medical Association, or AMA, has within their document in several different places. And what this simply means is that time that you spend doing something that can be reported separately to Medicare, you would not include that time when you're choosing your level of service. So for an example, if you have an interprofessional consultation, as an example, on that date of service for that particular patient, the time that you spend in that interprofessional consultation is not included in the time that you're going to spend on or use to choose your level of service. Another example could be that you're doing an evaluation and management service and you're doing a procedure on that patient on the same day. Maybe you're doing an injection into the joint, you're doing a lesion removal, something along those lines. When you're choosing your level of service, that time that you spend on that procedure has to be carved out of the time that you would use in order to choose your actual procedure code. If you're doing reading of a chest x-ray, and you're going to bill for the interpretation and report of that chest x-ray, then you would not count the time that you spent doing that in the time in order to choose your level of procedure code. If you're not going to bill for it, if you're simply doing a review of that chest x-ray, the chest x-ray itself, the report, that type of thing, if you're not going to bill for that separately, then you can include that time. The best practice is to identify the amount of time and the activity. Now, what we mean by this is we're not telling you that you have to stopwatch your practitioners. So your practitioner doesn't have to carry around, a little stopwatch. Oh, I've spent 3 minutes doing this and 5 minutes doing that, etc. However, the best practice is to identify the activities that you have provided for the patient on that day, and then notate the time that you have spent in doing those. One of the questions that we have received, a provider indicated that their electronic medical record identified for them when they started seeing the patient and then when they ended seeing the patient. And so they wondered what they could do with that information, because that's only the face-to-face time. Well, what that has to mean then is that the physician is going to document, physician or practitioner, is going to document within the record that I spent 10 minutes prior to the visit reviewing the patient's medical record to prepare for that visit. Then you would use not only the time that your electronic system has captured, but in addition to that other 10 minutes that the physician has documented in order to choose your level of procedure code. The goal of the documentation, obviously, is that another practitioner should be able to care appropriately for that patient. A secondary goal, though, is for someone else reviewing that medical record to be able to support and agree with whatever procedure code it is that you have chosen. So that means that if the WPS-GHA medical review staff ask for your documentation, we have to be able to see that, yes, you have 25 minutes documented, therefore the choice of your procedure code is fine, here's the medical necessity for the service, etc. So when you're looking at time, again, it has to be on the calendar date, has to show the medical necessity for the service, obviously, and then the time that you have spent on that patient. Now, one of the questions that we received has to do with differences between practitioners. The question specifically was, I have one practitioner whose average time spent with that patient, spent with patients is 35 minutes. I have another practitioner whose average time is 25 minutes. What do I do then? Well, if you're choosing to bill based on time, then those two practitioners are going to have different procedure codes. The American Medical Association has said that that is expected and that that is acceptable. That is the time that that practitioner has spent in caring for that patient on that particular calendar date. So now let's talk about extended time. This is that G2212 procedure code, and this is additional time spent on that patient on the date of that encounter, that patient encounter. The G2212 is for each unit of 15 minutes. Now, there is a difference between what the American Medical Association has published and what CMS has published. As we're aware, CMS generally goes along with the AMA, but not always. This procedure code is one of those situations where it does not go along with that. In order to bill for this procedure code, you have to have exceeded, well, number one, let me state, you have to be choosing your service based on time. And then you have to have exceeded the 99205 or 99215 by 15 minutes. The American Medical Association document indicates that as soon as you go past the time for the 205 or the 215, you can bill this code. Medicare does not agree with that. So for your Medicare patients, you have to go past that time by at least 15 minutes, if not more than that. So that means for your 99205, in order to bill the G2212, you have to have documented at least 89 minutes within your medical record. For the 205, you have to have documented at least 69 minutes. The other thing when we're talking about extended time has to do with the procedure codes 99358 or 99359. What CMS has published within the final rule is that these two procedure codes are no longer applicable in relationship to an office or other outpatient, again, the 99202 to 99215 procedure codes. So what that means then is that even if 2 weeks later, you're providing a non-face-to-face service for that patient, that is currently not billable to Medicare. It doesn't matter how far away you are from the related evaluation office or other outpatient evaluation and management code, the 99358 and 359 are simply not billable any longer in connection to the office or other outpatient code. Another question that we have had is, when you're talking about time, what happens if you don't meet the time for the lowest level procedure code? As we saw earlier, that 99202, the new patient code, it starts at 15 minutes. What if your physician doesn't have 15 minutes? Well, that means that they cannot choose their procedure code based on time. They would instead have to choose their procedure code based on the medical decision making, which we'll talk about in a minute. Another difference between Medicare and the American Medical Association is in the procedure code for this extended time. Medicare, for your Medicare patients who use the G2212 code, the American Medical Association has a procedure code 99417. This won't be valid for Medicare purposes. It will reject as an undeniable service.
Hey, Ellen. We do have a question, if you don't mind.
No, I don't mind at all.
Okay, this is from Deborah. Do you expect CMS to extend the telemedicine rules post-pandemic?
We're actually going to talk about telemedicine here in just a second. So I'll defer that question until we get done with that conversation, if that's okay.
Yep, I think she can hold on.
Okay.
And wait, we do have one other question. Now we're coming alive, people. This is good. If the provider documents time as part of their note, can they still bill based on MDM if MDM gives them a higher level?
Yes, and that's a very good question. The choice is yours, whether you bill based on time or whether you bill based on medical decision making. And you can make that choice either as a practice, make it one way or the other. You can make it based on a patient. You're going to bill this patient always on time, this patient always on medical decision making, or you can make it based on each individual encounter. And just like you said, Larissa, and what the questioner said, there are going to be times when either choosing your procedure code based on time or choosing your procedure code based on medical decision making could give you a higher level of service. That's entirely appropriate. And in fact, what Medicare recommends to you is that you document based on both. And then your coders and billers, when they're looking at the documentation, can see, okay, if we're going to bill based on time, I can bill a 99212 procedure code. But if I bill based on medical decision making, I have a 99213. Or, and therefore you could bill the 99213, or my medical decision making shows a 99213, but my time goes into a 99214. You can choose your 99214 procedure code. Both are acceptable with Medicare.
Okay, Tom, any other follow-up questions with that? Oh, no, he says that was an awesome answer. Thank you very much.
Right. As we stated, this is a major change. it is not only concentrating more on reducing physicians' burden in doing the documentation, it is kind of a whole different way of looking at how you're going to choose your level of procedure code. If you're choosing your level of procedure code based on time, then it is the time that your physician or practitioner is spending on that patient on that calendar date, reviewing old medical records, having conversations with the patient, all of those different things, documenting, all of those things we have talked about. If you're choosing based on medical decision-making, and we'll get into that in just a second, then you would choose based on the medical decision-making table that the American Medical Association has provided. And then, of course, with the extended time, if you are have additional time, then you would simply use multiple units with that G2212 procedure code, and that would be in increments of 15 minutes. And again, you have to meet the first minute. Once you get there, then you can build that code. You don't have to meet a midpoint. Excuse me. So we did provide you with the description of that add-on complexity code. And this code, again, is not going to be available until January 1st of 2024, as of what we know right now. That's a long time between here and there, so who knows what's going to happen with that. But we know it won't be available until then based on the Consolidated Appropriations Act of 2021. So it's statute right now that this code won't be available. So again, it is a B status code. It will deny as an unprocessable claim, or it will reject as not a separately payable claim if you actually bill for that. Now, we didn't go into a whole lot of detail on medical decision-making here in this presentation, as it's really bigger to go through all of that than what we have time for here today. The American Medical Association has a document, though, excuse me, that provides the table. So it talks about the problems that are addressed or analyzed, the amount and complexity of data, and then the risk information is on there. It's really a pretty good table. In the on-demand training that we have available right now, we have placed that out there in addition to the question and answer document. The other big thing, and I really encourage you to look at this American Medical Association document in the fact that it has definitions, which in a lot of cases we have really not had previously. So in this document, it tells you exactly what a problem is. It tells you exactly, it gives you a definition of what it means to address or evaluate a problem. There's definitions in there about what is considered an acute problem versus a chronic problem. What is considered a stable problem as opposed to a problem with an exacerbation. So I really encourage you to take a look at those definitions. It really does provide absolute fantastic service. So like I said previously, we have provided multiple educations on evaluation and management services. We've done a couple of presentations. We have simply opened it up for questions and answers, and then we're planning on doing another educational piece tomorrow. Again, registration will be open 2 to 3 sometime this afternoon, and then we'll be closing it after that. We also have the YouTube video that we talked about. So when we're talking about the medical decision-making, it's going to be the problems that are addressed or evaluated. So it's what your physician is actually performing and what they're dealing with on that particular date. Amount and complexity of data. This tends to be the area where we have quite a few questions in that question and answer document. One of the biggest ones, actually I guess two biggest ones, has to do with ordering the test and whether or not you can count the review of that same test as a separate data point. And the answer to that is no. The way that it is worded within the American Medical Association document is that when you're ordering a test, Medicare and the AMA for that matter is expecting you to review that test. So the order and review of a single test or the same test is part of the order. So you would only use that as one data point. Another big question that we have has to do with separately reportable. So for an example, if you are a physician's office and you have an in-house laboratory and you order a CBC or something like that for the patient today, they go down the hallway into your in-office laboratory, the lab does the test, and then, sends you the results. Since you're going to be billing for that test, well, let me put it this way. You have a choice. You can either bill for the test or you can count the order as a data point under the amount and complexity. You can't do both. If you have the patient there in the office and you are ordering a lab test and you're handing them requisition papers to go to the hospital outpatient department or to go to an independent lab and have this test done, then you can count that order because you're not going to be separately reporting the lab itself. Same thing holds true for if you have in-office X-ray or radiology equipment. If you're going to be billing for either the professional or that technical component of that radiology service or cardiology service, whatever it might be, then you would not count the order in choosing your level of procedure code. So it's kind of your choice. Do I want to bill for the lab test, and that's the more common one, the lab test or the technical component of a radiology service, or do I want to count that as part of my evaluation and management service, but you can't do both. And then, of course, the risk to the patient, the wording on this is different from what is in the 95 or 97 documentation guidelines. In the 95 or 97 documentation guidelines, it states that risk is the risk to the patient from the disease process or injury process from now until the next time that you are going to see them. That's not how it is worded under the new medical decision-making table. Under the new table, it is the risk to that patient based on the diagnosis that they have, which goes along with the problems analyzed and evaluated, and or the management options that you're determining. So for an example, in that MDM table, there's a section or a bullet point that says if you are determining that the patient needs to have surgery, then what is the risk to that patient from that surgical procedure? And so that would be part of where you would kind of choose in that MDM table which bullet point you feel like that would apply to. So that's kind of evaluation and management services, an overview of that. There are these additional things that we're going to talk about, but Larissa, I want to go ahead and stop and ask for questions at this time.
That means it's my turn to talk again. Anyone have a question? Give you a few minutes to think of them. So I actually have a question for you, Ellen and Mary. Literally, how do you keep all of this straight? There's just so much information.
Well, Mary and I both have worked with Medicare for a very long time. I think Mary has actually a couple years on me, and I'm over 36, or either I'm coming up on 37 or I'm coming up on 38. And so Mary has more time than that. And we did both start when we were 10, so, you know, we just want to let you guys know that. Mary and I both find all of this fascinating. And so digging into and researching and attempting to help our providers understand all of these different topics with Medicare so that they can treat their patients, they can get paid for treating their patients, because that's what Medicare is all about. And then Mary and I just have fun. We absolutely both have a blast at what we do.
Well, I think that is wonderful, and I just thank you guys for doing the work you do, because not everyone can do it. I can probably speak for all of us in that. So it doesn't seem like anyone has any other questions, so I guess we can continue.
Okay. So the next thing that we want to talk about are telehealth services. Now, this presentation is not going to talk about telehealth during the public health emergency. CMS has all kinds of information available on their website, and they're really kind of wanting and kind of controlling the education that is coming, that's coming out on that. There's a document, if you go into the CMS website, which is cms.gov, and of course there's a picture of the coronavirus on there. You choose that screen, and then on the first screen that comes up, scroll down under billing and payment guidance, and they have a document down there that is frequently asked questions to assist providers, is the title of the document. If you click on that, it's about 160, somewhere between 160 pages, and they have separated it out into all kinds of different topics in that particular document. There's information about the vaccines, there's information about the monoclonal antibody therapy, there's information for hospitals and dealing with the hospitals without walls. I mean, there's just all kinds of stuff. And as part of that, there's a section in there on telehealth services. What is payable based on telehealth during the public health emergency, how that all works in dealing with supervision requirements, in dealing with where you can provide services, everything else. So what we're going to talk about here today are the changes that CMS has made that are going to go forward. CMS published within several of their interim final rules information about telehealth, whether to make certain things permanent, whether to not make them permanent, et cetera, how those are going to work. And so in the final rule that was published at the end of December, then they have addressed what's all happening with the telehealth. So that's what we're going to be talking about next, are the services, the permanent changes that are coming along with the telehealth services itself. So the first thing that CMS is doing is they're adding a category of service. Right now, they have two categories, or in 2020, I should say. They had two categories. Category 1 were evaluation and management services for the most part, or services that were similar to that. So what CMS meant by Category 1 is that they could take a look at a service that has been proposed and could say, okay, this is really similar to this one that we already have on the list. Therefore, based on the information we have, we can go ahead and add that as a telehealth service. The other category that they had, and they still have, are what's called Category 2 services. These are services not similar to something that's already on Category 1, but it is services that the people who requested them to be telehealth provided additional documentation. So they were able to provide, here is why it is appropriate to provide this service through telehealth as opposed to face-to-face. Here is documentation we have on the outcomes for the patient and for the practitioners in providing this service as telehealth, again, as opposed to face-to-face. So Category 2 services had to provide documentation. It could be specialty letters, it could be peer-reviewed articles, all kinds of stuff that would show CMS why this is appropriate for telehealth. So that was Category 2. What CMS is also doing for 2021 is that they are going to add an additional category, and this is Category 3. Category 3 are services that would normally fall under the Category 2. And so what CMS is doing is, number one, they're going to allow them through the end of the public health emergency. And then, in addition to that, through the end of the calendar year following the end of the public health emergency. So what that means is that, miracles can happen. Let's say the public health emergency ends on April 1st. So these services that are listed as part of Category 3 then will continue through the end of, through 12/31 of 2021. At that time, that will give providers and specialty societies, interested organizations, et cetera, time in order to get all that documentation together so that they can submit to CMS to either show how this is a Category 1 or how this is a Category 2 and should be considered as that for telehealth going forward. Now, CMS has published within the final rule, and they have published the same statement multiple years, in that they will say that a certain procedure code has been proposed, but they cannot consider it because the request did not have all of the documentation or even any documentation in order to help CMS determine that this should be a Category 1 or a Category 2 addition to telehealth. So that's one of the things that you want to be looking at in looking at the information we're going to provide to you, so that if you really believe that one of these services in Category 3 should be continued on past the end of the calendar year that the public health emergency ends, you have time to get your documentation together, to get those articles, to get information on patient outcomes, to get information on how this and why, specifically why, it is appropriate to do this service this way as opposed to doing it in face-to-face. So CMS is reminding also the fact that telehealth is also covered by statute. And so the statute that is in place as of today, I have not seen anything come out of Congress yet that has changed this, but the statute as of today is that services must be provided in a rural area, and services cannot be provided in a patient's home. So that means that, for an example, you're there in St. Louis, during the public health emergency, you can provide services to your patients through telehealth, whether they're in their home, whether they're located within the St. Louis area, et cetera, because of the waivers. Once the public health emergency ends, then it has to go back to the statute, which is the services, with some exceptions, can only be provided in a rural area, and that's, you would have to use the patient zip code in order to determine that, and then also cannot be provided in a patient's home. I'm emphasizing this right now so that you have an opportunity now to contact your congresspeople, to tell them and remind them that this is actually still part of the statute. And with the very widespread application right now of telehealth services and the very widespread results of telehealth services to show that yes, this can be a very effective way of taking care of my patients, whether they're in their home or whether they're in a facility. This will provide you with an opportunity to contact them to have them change that statute. Once the waiver process is complete, which is after the public health emergency ends, CMS, I believe, can do that waiver through the end of the calendar year. They cannot take it any past that, though, which means that the home services or telehealth services you're providing in the patient's home would no longer be covered as of then. We wanted to let you know about that and remind you of that particular statute so that you can work with your specialty societies, et cetera, in order to provide this to your Congress people. One of the questions that we have had on telehealth right now, through the public health emergency, the supervision for ancillary staff providing telehealth services can be done through audio-video telecommunication. And what we mean by that is it is audio and video. It's not just one or the other. We don't anticipate that that's going to continue past the public health emergency unless CMS publishes something else. So in talking about telehealth services, on page 30 of your handout, we have a listing here, and this is a table from CMS published information about services that are going to be continued as telehealth. You can see on there group psychotherapy, domiciliary home services, which will be contingent on Congress changing that rule, the extended care time services on there, and then psych testing is also on there. The next information that we have, let me get down to that. Okay, then we have information on what is going to be considered Category 3 services. So we have here, these are the higher level domiciliary home, emergency department is going to be considered a Category 3, meaning that providers are going to have to put together that documentation to show why this service can be provided appropriately through telehealth. Nursing facility discharge visits, hospital discharge, critical care services, all of those types of things. So you want to take a close look at this Category 3 to identify whether one of the services that you're providing is in this category, and then whether or not you have documentation that you can submit to CMS to get it possibly placed in Category 1 or Category 3. Okay, so then we have information on services. Let me see if we've got a slide on that one. Okay, then we have information on services that are not going to be added as telehealth. So this is on page 31 of your handout, and these particular procedure codes will end. Right now you can do them as telehealth. Once the public health emergency ends, then these services will end the availability of telehealth at that time, unless, of course, CMS, comes back and changes that. I don't think the public health emergency is obviously going to end tomorrow. So this is another opportunity for you to put together documentation, again, peer review articles, et cetera, to show CMS why you believe this service should be able to be done as telehealth. So you can see here that a lot of these procedure codes are the initial codes, initial nursing facility, inpatient, domiciliary home, observation, et cetera. Medical nutrition therapy is also listed on here, where this service will no longer be available after the public health emergency ends. Okay, before we go into teaching guidelines, I do want to go ahead and, Larissa, see if we have any questions on that.
Okay, anyone? I think you addressed the previous question that was from Deborah. Do you expect CMS to extend the telemedicine rules post-pandemic? I think you covered that very thoroughly, so that's good.
Well, let me jump in here. You want to think about the procedure code and where this is at, whether it's a Category 1, Category 2, or Category 3. Because those things that are in the on page 31, services not added as telehealth, those will end the day that the public health emergency ends. So if it ends on August 1st, on August 2nd, these services will no longer be covered as telehealth. CMS has a document available currently out on their website, and you can get to that simply by doing a search for telehealth. And it's a document that shows services that are currently covered as telehealth. And as part of that, there's a column that shows whether it is a temporary ad. There's also a column that shows whether or not the service can be done through audio only, as opposed to requiring audio and video. You know, so you want to take a look at that also.
Okay, and then we did have a question from Karen. For a telephone call that lasts longer than 60 minutes, would be appropriate to bill 99443, which is a 21 to 30 minutes of medical discussion, and 99358 to account for the additional time on the call?
Oh, that's a really good question. Based on what CMS has published concerning the 99358 and 359 procedure codes, is that it cannot relate back to an office or other outpatient service. And that's all that they have said. They have not indicated that it cannot relate back to another professional service that's being provided for that patient. So I think that, yes, you could bill the 99358 and 359 in connection to those procedure codes that you mentioned. What I would suggest to you, though, is to go to the National Correct Coding Initiative pages and go into the add-on portion and verify that 99358 and 359 are listed as add-on codes to the 99443 procedure, 441 to 443 procedure code.
Okay, Karen, does that answer your question? Let's give her a minute. Yes, that answers Karen's questions. And then
Okay, good.
Also we have, Lori said that page 30 of the slide deck is blurry, so we can't read the telehealth category 3 services.
And it is, and we apologize that Mary and I played with that absolutely forever. The chart itself, and Mary, correct me if I'm wrong, but the chart itself is contained within the physician fee schedule final rule. It's either going to be in the one that was published on December 27th, I believe, or it is in one of the interim final rules.
Okay.
Larissa, if you would send that question to me by an email, I can provide you with the link and the page numbers of how to find those actual charts.
Yeah, absolutely. I can do that.
Okay.
Any other questions before we move on? Okay, doesn't seem like anyone else has any questions, so I'll let you guys continue.
Okay. The next thing that we want to talk about are teaching physician guidelines. This is another type of situation that has been a little different, well, a lot different through the public health emergency. And so again, what we're going to talk about are the changes that CMS are making outside of the public health emergency. So things that I'm getting ready to talk about don't change anything that's going on during the public health emergency. It's simply after that is over that these will take place. So CMS is making several changes. You can see there that first statement, and this is real important, it's when services are provided outside of a metropolitan statistical area, which means that the services are provided in a rural area. Excuse me, again, that's going to go back to the zip code of where the service is provided. You can go out to the CMS website, do a search for HPSA, Health Professional Shortage Area, and then there's a function there where you can enter the zip code. That zip code then will tell you whether or not telehealth services or these teaching physician guidelines now will be appropriate for that. Documentation has to continue to show the physician's presence during that service. That has not changed. However, services provided outside of an MSA can now use audio-video technology. And again, when we use the term audio-video technology, that does mean both. So the teaching physician has to be able to see the resident, has to be able to talk to the resident through that audio-video technology. So again, the documentation has to show the teaching physician's presence during that service. As you're aware, teaching physician guidelines state that Medicare pays the teaching physician for the services that he or she has rendered. If he or she is present during that resident's rendering of evaluation and management services to that patient, then the teaching physician can bill for that. So when we're talking about teaching physicians, if they're choosing their procedure code based on time, under the teaching physician guidelines, they would only use the time that they themselves have spent on that patient on that particular day. Under the teaching physician guidelines, the time of the resident would not count in choosing that time. If they're using the medical decision-making, then it would be their medical decision-making in connection with whatever else the resident may have entered into that chart. The teaching physician, under the primary care exception, can provide their direction, management, review discussions, etc., through the use of audio-video technology. And again, that's through primary care with the choice of the procedure code based on time. If it is under the primary care exception, you count both the resident's time and the teaching physician's time. So for an example, the resident had 15 minutes that they spent on that patient on that day. They came out, they spent 5 minutes talking with that physician. You would only count that 5 minutes once, you know, because you only count a unit of time once, but you can add that 5 minutes onto the 15 that the resident spent with that patient, and then bill based on time using that 20 minutes. Again, that's only under the primary care exception. In addition to that, under the primary care exception, they are going to add additional levels of service that that resident can be providing. They're also going to allow that resident to provide transitional care management and then the communication technology-based services. So the CMS is expanding quite a bit. However, you want to remember that it's only, these expansions are going to be for services outside of a metropolitan statistical area. What CMS published within the final rule is that this would be an encouragement and an improvement on patients having access to additional care within their rural areas. The next thing that they have, or that they talked about under, and we put it under the teaching physician guidelines, but it really has to do with the residents, and this has to do with moonlighting. So as you're aware, residents, if they are already licensed to be MDs or DOs, can provide services outside of their graduate medical education program, and that's, of course, called Moonlighting. Now, the rules have always been that they can provide these services in an outpatient setting, so like in the emergency department of where they're receiving their training, et cetera. The rules have never allowed them to provide inpatient care. What the rules previously stated was the inpatient care was part of their graduate medical education and their residency program, and so therefore Medicare would not make separate payment for that. This is now changing based on the new rules, so that resident now can provide inpatient services in that same facility. There has to be additional documentation, and that's going to have to be within the medical record of that patient that would identify the resident stating something to the effect, I provided services to this patient while I was moonlighting. There is no GME reimbursement for that, the graduate medical education reimbursement for that, et cetera. You also have to, if you have a resident who's going to provide this type of moonlighting, you also have to make sure that your coders and your billers are going to be aware that the resident is going to be providing this. Generally speaking, of course, the inpatient services were where that resident's time and services provided, everything else, would go into that graduate medical education program, and then that's reimbursable back to the hospital by Medicare. Well, if the resident is moonlighting, which means he or she is going to be billing Medicare directly for the services, then that information should not be part of that GME program. So you just want to make sure your documentation actually shows that. In your document, we have information there on the teaching physician guidelines in the internet-only manual, and then we also have information there on a fact sheet that CMS has put together on teaching physician guidelines, which would include teaching physician, primary care exception, and then the moonlighting would be there also. All of the rest of the guidelines for teaching physicians, the physical presence or the presence, let me put it that way, of the teaching physician while the resident is providing services, the teaching physician under primary care exception, that they are having interaction with that resident after each of the patient encounters, all of that information still stays the same. Okay, Larissa, we'll go ahead and ask for questions on this before we move on.
Okay. Anyone questions? Anyone? We'll give it another minute. Give your voice a rest, you know.
That's okay. And you know, I have done presentations for your group several years now. You guys are not this quiet. So, you know, now is an opportunity for you to kind of type in your question. Larissa will pass that on. Mary and I would be more than happy to answer any questions you have.
Yeah, I highly suggest taking advantage of this time. I know attending the live events in the past, there's been some more engagement. I know it's different with a virtual event and everything, but
Sure.
Don't be shy. It's just typing. You don't even have to raise your hand. It's an introvert stream, you know. We do have more time for questions at the end too. So I think we can move on for now.
Okay. The next thing that we want to talk about is pharmacist and incident to services. And this is something that we have heard from physicians and practitioners for multiple years, absolutely multiple years. there's a lot of different services that pharmacists can add or can provide to the patient, which really adds to that patient care. And so we've had questions concerning how can we bill for the services that the pharmacists are providing, et cetera. Okay, so it has always been that, number one, you build a procedure code that most accurately reflects the service that you are providing. In some cases, what the pharmacist is doing is medication reconciliation, and that's really kind of all that they're doing. And I don't mean all that's not a valuable service, but it means that they're not doing anything other than that for the patient. Well, there's a procedure code out there for that. That code is not a payable code by Medicare at this time. However, if your pharmacists are providing not only the medication reconciliation, but also additional services, you can provide that pharmacist can provide that under the Incident to guidelines, which means that the physician could bill for that particular service. Now, there are some rules and regulations that go along with Incident to. Number one, that pharmacist has to be an employee of that physician or that physician practice. Now, they don't necessarily have to be a W-2 employee, but they do have to have an employment relationship. In addition to that, the services have to be provided within an office setting. The physician or practitioner who's going to bill for the service has to be on site. Again, a little different through the public health emergency, but has to be on site. And then the procedure code that can be chosen is the 99211 procedure code only. Now, a lot of conversations that we have had concerning pharmacists and the services that they're providing to the patient, just based on the descriptions, would lead to or would lead one to think that it's a higher level service. And obviously I don't know that. However, the CMS rules and regulations under the Incident to provision is that only the 99211 procedure code can be submitted when someone other than the physician or practitioner is providing those particular services. So as long as your pharmacist meets all of the Incident to requirements, again, employment, location of service, procedure code, part of the care plan set by the physician or practitioner, then the physician or practitioner can submit that, again, using that 99211 procedure code. The other thing that you want to, the other thing that you want to look at, though, is that the service is not something that could be billed to Medicare Part D, as in drug, under the patient's drug program. If it is, then the pharmacist wants to be billing that direction as opposed to the physician or practitioner billing into Medicare Part B. And then we have provided you, again, a link to the Incident to provisions so you can take a look and get more information there. The next thing that we want to talk about then is medication-assisted therapy in the emergency room. Mary talked earlier about the opioid treatment programs, the substance use disorder programs that are out there. What this is now going to do is provide an add-on to your emergency department procedure code, and you can see the code there on page 34 of your handout, the G2213. What this is actually going to do is if your emergency department physician is treating that patient, and maybe they're treating them for an overdose, I can't say that. Maybe they're treating them for something else related, and they identify that the patient has an opioid use disorder. Maybe simply through their conversation with the patient, they understand that the patient has this opioid use disorder. What this is talking about is it works very similar to the other services that are part of the opioid treatment program services. So you can see a listing here. This is going to be the initiation of medication for the treatment of opioid use disorder within the emergency department. So maybe your emergency department physician is providing the patient with either a prescription or the medication, the buprenorphine. It's including an assessment of that patient. Are they, kind of a danger to themselves? Can they, are they interested in the therapy, et cetera? It's referral to ongoing care, arranging access to supportive services, et cetera, listed there. So this would be part of, or I'm sorry, let me rephrase that. This would be an add-on code in addition to the emergency department procedure code that physician or practitioner would normally bill anyway. You just want to make sure that you have documentation within your records that support the description of that particular procedure code. Now, the medication itself, if you're providing that to that patient at that particular time, the facility then would bill for that medication. It would not be part of the physician's billing itself. And again, documentation is really going to be essential because you want to show, not only do you believe that the patient has an opioid use disorder, but what your physicians and practitioners are doing for that patient at that time. A notation within the statement or within the medical record that I told the patient, hey, quit doing this because it's dumb. That's not going to be enough documentation in order to support this procedure code. It is going to be an assessment of where that patient is at in connection with that, referrals. So you could be providing the patient with information on individual practitioners. You could be providing the patient with information on community resources and things that they have. And then, of course, arranging access. So doing that referral to that other practitioner, et cetera. So the next thing we want to talk about then are changes to the Welcome to Medicare visit or the initial preventive physical exam and the annual wellness visit. On page 35 of your handout, we have listed for you the procedure codes for these services. The basic change in this is formalizing the inclusion of the opioid and substance use disorder development within these services. It's always been part of the service itself. CMS is really just now kind of making it more formalized that this really does have to be in there. You have to be having conversations with your patients concerning substance use disorders, opioid use disorders, when you're providing these two services. So then the description includes more specific language, and you can see that there on your particular handout on page 35. Review of potential risk factors. Have they had substance use disorders in the past? Are they taking opioids, et cetera? Referrals for treatment as appropriate. So if you're identifying a patient who has a substance use disorder, what are you doing with that information? How are you encouraging the patient to continue with the treatment or start treatment, et cetera? Now, I want you to look there under the review of current opioid prescriptions. There's several things listed there. Number one, you're going to be asking them, obviously, if they're taking any. If they're not, then some of this information may not apply. But you want to be reviewing their potential risk. So have they had a substance use disorder in the past? Have they had problems with alcohol in the past, which could lead to that? The other conversation that you need to have and needs to be documented within your record is their pain severity and their current treatment plan. Now, this does not necessarily mean that you are the one treating whatever is causing their pain. You know, that could be another provider who is taking care of that. But as the one providing the Welcome to Medicare visit or annual wellness visit, then you need to be identifying that also. How much pain is the patient in? If you're not the one treating the cause of the pain, then what is the treatment plan that has been developed by that practitioner who is treating the patient for that pain? The other thing that you want to be doing is informing the patient about any additional non-opioid treatments that may be appropriate for that patient. So can they use a topical pain reliever? Would that be a better choice for them? Can you start them on physical therapy that could maybe help alleviate some of the pain that they're dealing with? Is there an underlying condition that maybe needs to be treated that would do away with that particular pain? I mean, there's all kinds of different reasons why patients are in pain, all kinds of reasons, different reasons why patients are taking the opioids themselves. And you want to have the documentation contained within the medical record, obviously. I saw an interesting piece of documentation on one, it's been several months ago, where in the documentation, this was just an E&M service itself, the physician stated, I invited the patient to try a different pain management treatment plan, and the patient declined. Okay, so what do we do with that? We know that opioids are kind of a big problem across the country. We see things coming out from the Department of Justice and Office of Inspector General all the time, where providers are getting in trouble with Medicare because of issues that are related to prescribing opioids. As the physician or practitioner, you're the one who is setting the plan of care. So, you know, if the patient kind of doesn't want to get off the opioids, but you have identified that this is a problem, then you really don't want to leave it there. And in your documentation, you want to identify kind of what it is that you're doing with that particular patient in order to help them move off of those opioids, if it is at all possible, obviously. And then in the changes for the Welcome to Medicare visit and annual wellness visit, CMS just again emphasized, I guess is the word I want to use, the fact that you can have a medically necessary evaluation and management service on the same day as you're doing an annual wellness visit or a Welcome to Medicare visit. If you're providing these on the same day, then you just want to make sure that your documentation supports that. For an example, if you're using using time in order to choose your procedure code, you want to make sure that your documentation carves out the time that you have spent totally on that patient for what goes with the Welcome to Medicare visit, and then what you have left, then of course could be used for your E&M service. Okay, the next thing that we want to talk about then is remote physiological monitoring. Remote physiological monitoring, I guess the first thing that I want to say concerning this is that it is an auto transmission of information. And what I mean by that is that the patient has some type of a device where they can, or where that device rather, would auto transmit that information into the physician or practitioner's office. A patient calling you up and giving you their blood pressures for the past week, that is not part of this. Remote physiological monitoring is where it is auto-transmitted. In addition to that, your system would have alerts built in so that, you know, if it transmitted today, and we'll say with blood pressure, and their blood pressure is what, 120/80, I think is supposed to be the standard. But today's transmission is 250/120. There needs to be bells and whistles going off within your office so that someone is alerted to the fact that this particular monitoring has indicated that there's a problem and maybe something else needs to be done with that. Also, as part of this, there has to be interactive communication with that patient or the patient's family or caregiver. And what we mean by that is that you would not be able to simply send a text message back and say, everything looks good. That's not an interactive communication. You would have to have a response back from that patient. You can do this through technology, so this could be you know, calling the patient, it could be text messaging, as long as you're getting that interactive communication through your patient portal, again, as long as you're getting that, that interaction. CMS is now also going to allow this for both your acute and your chronic patients. So it's not just a patient who's been a diabetic, you know, forever. It could also be a patient that just found out they're diabetic and they seem really committed to making the changes necessary. You can also do this for them. Now, you have to have at least 16 days worth of data in order to bill for this. So that's 16 days within a 30-day period. You would bill for this after that 30-day period. It's kind of like some of the other services that you can provide over a length of time. Now, the next bullet point there, it says must be a device recognized by the Food and Drug Administration. This one gets just a little bit tricky because it doesn't have to be a device that can be billed to Medicare. It just has to be a device that the FDA agrees is a medical device. I'm trying to think of an example of one. Patients wear a patient could be wearing a Fitbit that could be transmitting information to your organization. Now, a Fitbit is not something that is currently payable through the durable medical equipment. It's not identified as a piece of equipment for Medicare purposes. But if the FDA, and I don't know this, but if the FDA recognizes that as a medical device, then you could count that. And therefore, that transmitting information, you evaluating that information could be part of the service. Now, the next thing that we have on your slide there on page 36 is the procedure code. Now, I apologize to you. We have used the short description of the procedure codes. As you are aware, of course, the American Medical Association holds the copyright for the CPT codes. And they have rules as part of their copyright as to when you can provide the long descriptors, when you can provide the short descriptors. In this case, we needed to provide the short descriptors. So you can see there that first procedure code, the 99453, this is when you are starting an episode of care. So the patient was just diagnosed with high blood pressure. And so you are starting a treatment program for them, and a remote monitoring device is going to be part of that. This procedure code is when that episode of care starts. And then the episode of care is going to end when the patient either is at treatment goal or you determine that you no longer need that information. So let's say your patient, again, starts out with a very high blood pressure. They are committed to making the changes they need to make. And so you provide them with this device, or they have a device, either one, and you're going to monitor this. So you monitor this patient for 6 months. They're doing fantastic. things are coming in, they're at their treatment goal, everything is working good. And so you say, okay, we don't need to monitor any longer. Okay, patient comes back to you a year later, they're not doing so good on that anymore. They really have kind of not been following the diet, the exercise program. You now have a new episode of care should you decide that you want to provide this service to that patient. So this includes the device setup and any education to the patient on how to use the device. You know, I want you to use this at 8 o'clock every morning and at 8 o'clock every night. Here is how you actually place the cuff on your arm in order to gather the information that we need, etc. The 99454 is actually providing the device to the patient. The next two procedure codes, the 99091, this is the collection and interpretation of data. This is a 30-day procedure code. And then the 99457, this is the development of your treatment plan. Now, here's another situation where information between the American Medical Association and CMS are very different. The American Medical Association indicates within the CPT book that you can't bill both the 99091 and the 99457 at the same time. Medicare says, yes, you can. Medicare believes that the collection and interpretation of the data is a different service than actually the development of a treatment plan based on that data. So for your Medicare patients, you can bill both of these. So let's talk about the development of that treatment plan. This is going to be where you're evaluating the report of the data that has been provided to you or to your practitioner, and then they're determining, okay, what should happen next? Well, it could be that nothing different should happen, that everything that you have advised the patient, any medication that you have started the patient on, physical therapy, cardiovascular, exercises, any of that kind of stuff, everything is working just perfectly, and you want to keep the plan the same. You have developed your treatment plan. It could be that you want to make some adjustments. You're going to adjust the plan. You're going to provide that information back to the patient on what that adjusted plan is. So that also goes into that 99457. And you can see here, this is the first 20 minutes, and then you have the 458, which is at each additional 20 minutes. Okay, the next thing that we have here are just some different things that you need to know. One of the things that we want to talk to you about are appeals. Appeals cost you money. Appeals cost us money as a Medicare administrative contractor. One of the things that, or I guess let me put it this way, one of the largest reasons that we are receiving appeal requests is because the original or a claim denied as a duplicate. Now, there are several different reasons why this could happen. One of those is that the claim was submitted twice. One of those could be that the claim was submitted without the appropriate modifiers. But what happens with that is that because the claim was not handled correctly, it's going to take you longer before you receive your payment. A payment floor on a claim for an electronic claim, what we consider a clean claim, meaning there is no development or anything, Medicare pays within 14 days. An appeal, Medicare has up to 60 days in order to process that. So let's talk about the first one, which is Medicare has denied it, stating that we have already paid someplace else. One of the things that we have seen is that providers will have their auto repay or auto rebill set too soon. As we talked about, there's a 14-day payment floor, meaning that we can't release payment, even if we approved it on day one, we can't release payment until 14 days. So you don't want to be submitting a claim again prior to that 14-day time frame. For Medicare purposes, you don't want to resubmit a claim ever until you know what happened to the first one. So for an example, it could have rejected before it got into our computer system. There are reports that come back to you or to your clearinghouse when you're submitting claims to us. Check those reports. You could have received a previous notification from us that this was applied to the patient's deductible. So you didn't receive a payment, but Medicare has approved the service. So you want to, before you resubmit a claim, you want to identify what happened to that first one. The way that there are several ways that you can do that. We have an interactive voice response system that you can use. And then we also have our web portal where you can go into the WPSGHA.com website, sign in, and then you can look for your NPI number. You can look up the patient, the date of service, and find what happened to that original claim. Once you know what happened to that original claim, then you know or have a better understanding of what you need to do next. Okay, so let's talk about ones where a modifier was not on there. There's a couple of situations that you have here. The more common one that we see is that the patient had maybe, let's say, a left hip replacement done a couple years ago. That claim came in without a modifier. So that claim is in history, and you can really only kind of have one of those. And so since that claim is in history, when the new one comes in for the right hip replacement, we're going to deny that because we've already paid for it. If that claim, that second claim is submitted, even with an RT modifier, we're still going to deny that because we don't know what the first one was. So the advice to you there is that if you can use an RT or an LT modifier when you're submitting a claim, always use it. If you can use the finger modifiers or the toe modifiers or the eyelid modifiers to identify specifically where that service was provided, always do that. Another big area that we see are multiple services within a day. Chest x-rays are a big one for this. You have patients whose condition requires multiple chest x-rays. Excuse me, I'm sorry. And so the way that this should be billed to Medicare is that all of those services should come in on one line with multiple units. So if you're a practice where this happens quite often, where you're doing multiple services within a day, then you need to build within your system a way to hold those until you get everything in. And then that way you can submit them one time, your chest x-ray procedure code, your multiple units of service, pricing for all the multiple units, and then you probably won't be denied. Another area where we see a lot of duplicate denials has to do with medically unlikely edits. Mary talked about those earlier as part of the National Correct Coding Initiative. The medically unlikely edits is where CMS, through its contractors, has determined, for an example, that 3 of these are appropriate, 4 of them are not. Okay. And so what you want to do in this situation for those services that are part of MUE is you want to submit them all on the same claim. So again, this could be a situation where you need to build into your system, editing that will stop those procedure codes prior to them coming into us. When you're submitting those codes, you want to submit one line on the claim with the MUEs that go along with the National Correct Coding Initiative. So in our example, we said 3 was appropriate. So you're going to have one line that has 3. Your next line will have 1 unit of service. Now that service is still going to deny, and it will deny based on the MUEs as opposed to denied based on it being a duplicate when it's on the same claim. If it's on a different claim, then it will deny as a duplicate, and then that means when you're requesting an appeal, you may not necessarily be providing us with the correct information. Another thing that we want to let you know about is that our portal is updating all the time. We have really great information out on our website, and then once you go into the transactional portal, there's wonderful information there. We're continually looking at, based on your suggestions, we're continually looking at additional functionalities that we can provide to that portal for you. What that means, though, anytime we add something, it means that the manual gets updated. The manual for the portal, which is an absolute fantastic document, it really goes into each of the different fields, all of the different functionalities that you have available. But what that means is that when we update that, we have to update that manual then on our website. If you go down to the bottom of each and every page on the website, you'll find a link to the portal manual, and then it will walk you through all of the different changes that we have. The next thing I want to talk to you about then is our YouTube channel. We're pretty excited about that. We have all kinds of different education out there. We have presentations lasting a minute and a half that provide you with great information. We have, I think, at least one, and it could be the evaluation and management one that goes about 20 minutes. The topics are all across the board. One of the presentations that we have out there on our YouTube channel walks you through exactly what you need to do to sign up for a course in our Learning Center, exactly what you need to do with screen prints and everything, exactly what you need to do in order to get the teleconference number and the conference code and the unique ID that goes along with you specifically. The person who did this absolutely did a wonderful job. So we want you to subscribe to our YouTube channel so that you are notified when we're placing new videos, new education out there. And then, of course, we've started including publications when we add stuff to the YouTube channel in our Wednesday e-news, which is our training e-news. So if you're not already getting that, it's real easy to sign up for that. You simply go into our website. I think it is at the bottom left-hand side of the page. Enter your email address in there, and you're signed up for our information. The next thing that we want to talk to you about is a new functionality that we have available on our website. CMS is changing some of the ways that they are going to be gathering information from the provider community. As you're aware, CMS has done different surveys to the provider community in the past. We have published links to those surveys. Well, now CMS is switching to a new way to gather that same information. And our website, the page that you see up there on the screen right now, really is kind of how they are gathering that. And so what this is doing is it wants to know your opinions on the website. Are you finding what you need? Is it easy to find what you need, etc.? So on the right-hand side of your screen, there's what we call a constant button, and it says feedback. It's going to show up on every screen you go into on our website. If you find something that you absolutely love that we have put out here, then click on that button. Tell us that you absolutely loved it. If you are looking at a particular document and you go, oh, wait a minute, they could have included a paragraph on this, whatever this is, and then it would have been complete, hit that button and tell us that. On the right-hand side of your screen that you're looking at right now is a pop-up box. This will pop up randomly, kind of like the old 4C survey did, and then it will ask you to share your opinion. So you can certainly share information there. We want to encourage you to share with us both your likes and your dislikes, things that you think we could improve upon. We pay attention to the information that is provided to us through these surveys. We have a whole process set up for this. And so if we get a comment that says, hey, wait a minute, you know, you have information on this screen on certificates of achievement. I don't think this should go here. Okay, if that's the only comment that we have, then we have to evaluate, is that a valid comment? Do we need to go ahead and make that change? And what has happened to us in the past is we've said, okay, you know, this is the only person we've heard from, and so we have changed something, and then we hear from 27 other people that say, we love that. Why did you change that? So let us know those things both you like and that you dislike or feel like we could do better. And so the next thing that we have then is we can open it up for questions. Larissa?
Yeah, we actually do have a question from Trisha. So it hasn't been discussed today, but she's having trouble sending 81002 UA and 87804 influenza rapid test or the 87880 rapid stress test. She says, we have a CLIA certificate. Do I have to put the modifier QW for any of these tests that we do?
Ellen, I can answer this. Whoops.
Sure. No, go ahead.
I'm prepared to answer this. I saw the question come in, so I did a little surfing behind the scenes while you were chatting and presenting. There is a modifier QW fact sheet that we have available on our website, and I sent the URL over to Larissa in a chat message so she can provide that for you. Within that fact sheet, it tells you appropriate uses of that modifier, inappropriate uses of that modifier. And if you think that your denial is related to the whether or not you use the QW, you probably have a very good inkling in that, but without seeing what happened to your claims, I can't really tell you that and verify that. But do take a look at that QW modifier fact sheet. It's full of some great information, appropriate uses, not appropriate uses. It provides you that list of CLIA waived tests that do require that QW modifier. So I think that's what's going to help you. But like I said, without seeing what happened to your claim, I can't tell you specifically. That's why for claim-specific questions, we typically steer you over to customer service because they can help with any claim-specific or any provider-specific questions. They'll be happy to help you.
Very good. So Trisha, does that help answer your question? Yes, great, thank you. So we have another question from R. Duncan. Sorry, I don't know your first name, but that's all right. So how does Medicare set-aside work? We have a patient that is claiming that the set-aside is depleted. How much is the patient responsible for?
Okay, so this is a Medicare I believe this is a Medicare secondary payer situation where as part of a settlement, the patient has however the settlement works, the patient has access to a certain amount of funds that are supposed to take care of their medical expenses, until those funds run out. So if the funds have run out, if the patient is telling you the funds have run out, then that means that there may need to be some changes within their Medicare secondary payer identification information. The best thing to do is to contact the, it's the BCRC. Mary, what that means, just went out of my head. It's Reconciliation Contractor, BCRC. You're on mute, Mary. Okay. So what does the BCRC stand for?
It's the Benefit Recovery and Coordination Contractor, I believe.
Okay.
Or benefit, yeah, I'll find it.
Okay. I had it, and then it fell out of my head and ran out the door. But what you want to do is you want to contact them. They're the ones who kind of control the Medicare secondary payer information, which is filtered out through all of the MACs. We have information available on our website. You can go into our website, do a search under BCRC, and you'll have several pieces of information that comes back. We also have information out in our YouTube channel. There are several different Medicare secondary payer presentations out there, videos out there. And then we have more complete information on Medicare secondary payer within our Learning Center through on-demand training.
Okay. So
And I have confirmed, Ellen and everyone, that it is the Benefit Coordination and Recovery Contractor. That is the BCRC. I have to look it up too. I can't always remember it in the right order.
No kidding. Too many acronyms.
Okay. I hope that answers your question. I'm going to mark it as such. Now, Ellen and Mary, you guys are open for questions about things that were also not covered in this presentation, correct? Within reason?
Mary and I can take questions within reason. As Mary talked about earlier, we don't have access to the processing system. It's just, that's not part of what systems we have access to. Claim-specific questions do need to go through our customer service area. You can do that through a phone call to one of our representatives. You can submit that through an email on our website through the Contact Us, which is up in the right-hand corner of your page. You can submit questions, inquiries through the portal itself. But if there are questions, we can certainly see if we can assist.
Okay.
Ellen, while we're still compiling that list of questions, I just want to really quickly throw out that I have some Facebook groups that I belong to, and I very, very often see comments out there that providers or people who are needing to keep up with their accreditation need CEUs. And I just want to let you know that the MACs and CMS do offer either certificates of achievement that you could turn in to obtain or for consideration of CEUs. You know, there's some that actually provide you with the CEU certificate, although WPS-GHA provides you with that certificate of achievement that you can turn in. Please be aware of that. These are free CEUs or free mechanisms for you to get your hands on those CEUs. I know a lot of you are sometimes in a time crunch to get those CEUs, so I did want to mention that. If you take a course and you successfully complete that course in the WPS-GHA Learning Center, most of those courses are going to allow you to access that certificate of achievement that you can turn in for the CEU consideration. There are certain organizations, they're all listed out on CMS's website, that do take the MAC education. You know, for example, they'll allow 1 CEU per instructional hour. So there's an entire listing of those that do accept the MAC's education or CMS's education. So I just wanted everyone to be aware of that.
Very good. Well, I know that they're earning 2.5 CEUs for today's presentation, so that's definitely very helpful. It doesn't seem like we have any other questions at this moment. So what I'm going to do is I'm going to transfer over to the, we have another 1-minute video. Let people watch that, think about a few more questions, come back. We'll have like 5 minutes or so to talk, and then we'll just wrap it up. Time has flown by this morning. So let me do that really quick. So bear with me while I do this.
Larissa, do I need to stop sharing then?
It'll stop automatically once I transfer it over.
Okay.
We want to thank you all for attending the virtual conference today. I know it's not the way we've always done it, but one thing I think you've seen St. Louis MGMA do over the years is adapt and prosper. I know I miss sharing stories and getting together with you and benefiting from each other's company, but I know that we'll come out of this stronger. I know that we'll help each other, and I look forward to seeing you at the conferences as they come up. But for now, I really appreciate you tuning in. We've adapted. We're going to come out of this stronger. And when we do, we'll all be here together, benefiting from each other's strengths. Again, thanks for tuning in today, and I look forward to seeing you in person. Stay well and prosper. We want to thank you all for attending
Oh, hold on. Okay. So thank you for that somewhat Star Trek inspired words, Jeff. We definitely can get on board with that. So we did have another, I'm going to turn my volume down. Hold on. We did have another question from Julie. So when billing G0452, physician interpretation and report of a molecular pathology procedure, is it required to have an opt-out option on the order for the interpretation? If so, can you direct me in the right direction in obtaining information?
Mary, I have absolutely no clue. This one, I would submit this as an inquiry to our customer service area. And what I would actually do is submit this as a written inquiry, either through the Contact Us or through the portal. I think our staff that answered the written inquiries, I think, would be able to assist you more.
I completely agree, Ellen. I'm not familiar with the verbiage used in the question. The opt-out option on an order is unfamiliar to me.
Okay, so Julie, I hope you can direct your question to where they indicated. They can definitely get some help for you. So Julie says thank you. So that's kind of last call for questions, and then I will wrap everything up. So we'll give it another minute or so. Okay, all is quiet. So I am going to do the conclusions, and if anyone has one last thing to slip in at the end, we might just take it. So thank you again for Ellen and Mary, and thanks again to the business partners whose contributions helped to make this programming possible. Big round of applause to all of our sponsors, including gold sponsor Keene Insurance Group, and silver sponsors Epoxy Healthcare, Sandberg and Phoenix, and R3 Dynamics LLC. So keep an eye out for an email from us with session handouts, the AAPC CEU certificates, and on-demand viewing information, vendor and speaker contacts, and a survey to complete about today's presentation. We really appreciate your feedback and use your input to improve the quality and responsiveness of our educational events. Also, don't forget to join us for the next virtual webinar sessions, Wednesday, March 10th on Toolkit to Manage Any Employee Problem, April 14th on Diversity and Inclusion in the Workplace, and May 12th on Marketing and Communications to Improve Patient Engagement, and they all run from noon to 1. You can find out more on the website and social media. Definitely follow us on social media if you want to. That's a good way to keep updated on things. We also do a lot through our email list. And last, if you haven't already, don't forget to renew your membership for 2021. There is that deadline of February 15th. So we appreciate your support of the MGMA in Greater St. Louis. And I don't see any other questions, but we have a few comments. If you have comments for the speakers, you can put them in the chat and I'll read them out as a wonderful encouragement for their time and to thank them. So we have a thank you in all caps from Chris. From Stacy, we have great presentation as always. Thanks to presenters for breaking it down for us. Karen says, thanks to all for another great Medicare update. Deborah says, great information. Thanks so much to our great presenters. So I think that's positive all around. And I'm going to call it for today. Thank you everyone for joining and participating, and definitely check your email for those follow-ups. Have a great rest of your day.